My name is Holly Vanderheim. I'm an adult geriatric nurse practitioner with Destiny Hospice and Palliative Care, and I'm also a certified hospice and palliative nurse practitioner. And I'm going to talk today a little bit about end of life as it relates to hospice. A question I get a lot of times when I'm evaluating somebody or admitting somebody for hospice is what kind of things should we look for? How do we know if the time is getting close? So I thought I'd talk about a few of those things today. So first of all, let's just agree that no matter what kind of a timeline anybody has given you, it's always an educated guess. Nobody knows absolutely positively when somebody is going to pass away from this earth. You can guess based on education and experience, but it's always up to somebody else other than us. So that's the first thing I wanted to just kind of explain, because a lot of people, well, how long does this person have? They want to know. And there's really honestly no way to know for sure. It depends on so many things. And if you ever get to the point where you or somebody else is being admitted to hospice, that person who is admitting you can go through all the various things that happen that influence how long somebody's going to be with us. So the thing that hospice looks at, and specifically Medicare, is if you have a life expectancy of 6 months. Now, that's what it says in words, but how that translates into real life is if you look at somebody's decline over the last, say, 3 months, 6 months, look at them now. Look at their medical records, look at what their comorbidities are, their various chronic diseases, health issues. Project 6 months in advance. Is there more of a chance than not that that person will no longer be with us? If the answer to that is yes, honestly, then you can look for a way to make them eligible for their hospice benefit. So I always tell folks it's the prognosis, not the diagnosis, that qualifies somebody for hospice. If you can honestly say that this person will more than likely not be with us in 6 months, they are likely hospice appropriate. And then once that decision is made or that assessment is made, then you look at the records, you do the exam, you figure out what diagnosis is most likely to take this person's life. And that's the diagnosis we use to put somebody on hospice. So the first step, obviously, is having a terminal diagnosis. That is not the case for palliative care, which is a completely different matter. That's only the case for hospice. Hospice needs to have a terminal diagnosis. Then once you get that terminal diagnosis and you get admitted to hospice, then one of the most important things to realize in your mind in the beginning is this person is going to possibly go from independence to dependence. If they're independent when they first get admitted to hospice, chances are, if they follow the trajectory that is expected with their disease, they will go from being able to do everything for themselves to being dependent on somebody else for maybe almost everything. So one of the most important things that hospice does is provide symptom management. Symptoms are inclusive of pain, appetite, bowel management, skin management, and just kind of management of the symptoms that go along with being debilitated and getting deconditioned and getting weaker. Pain is a big deal. It's the biggest deal for a lot of people. So we have lots of interventions and medications available to deal with pain. Everyone knows about morphine in hospice. Morphine is one of the tools we use, but it certainly is not the only tool. We have tools to deal with many other things besides just the morphine. We deal with nausea and anxiety, bowel problems, lots of things that when somebody is admitted to hospice, that person will be educated about all the details. Nutrition. Nutrition is something that usually goes down. Intake goes down as somebody declines. Either they feel nauseous, the thought of food just makes them want to vomit, or they just have zero appetite. Maybe they get uncomfortable if they eat, or maybe they just don't want to eat anything. So it could be swallowing. Maybe they have trouble swallowing, so you'll have to go to soft foods, or liquid or pureed. And then the anorexia is basically just no appetite. Nothing tastes right. There's just no desire for food. That does happen sometimes. Deconditioning, just as a result of being much less active than you normally would be for the rest of your life, your prior life, just either being bedbound, spending a lot of time in the recliner, just being too tired to do much of anything. Little by little, you will lose muscle mass because, use it or lose it. So if you're not able to use it, you will be losing it. It's just a fact of life. Skin breakdown is something that happens if somebody is bedbound or chair-bound, if they're unable to move themselves, readjust. You know how when you sit someplace in one position for too long, it just kind of gets uncomfortable, and so you just naturally move. Well, if somebody is too weak to move themselves, then that position has to be changed by somebody else to allow that skin to get the circulation that it needs to stay alive. Because if you have bone pressing down from one side and a pillow or a floor or whatever the person is on pressing on the other side of the skin, then there's not going to be any circulation in that skin. It will start to die and it will break down. So that's a very important consideration when somebody is not moving around as much as they used to. Bowel management is a huge deal. Bowel management is all kinds of different concoctions and interventions that we can use, because when somebody's debilitated, they're not moving around, they're not eating well, they're not probably drinking the fluids that they need to drink, and there's still stuff in that colon and that small intestine, and we have to keep that moving, because if we leave it in there too long, it will get to the point of being an obstruction. So we want to keep things moving, we want to keep things soft, drink fluids as tolerated, and use whatever preparations we recommend to keep those bowels moving. Self-care for the family caregiver, you have to, if you are a family caregiver, you absolutely must take care of yourself. Accept help when it's offered. Find a friend who can come by for an hour or two or however long to spell you. Be able to take a walk just to decompress. It's very, very emotionally draining to be taking care of somebody, especially somebody you love, who's dying, who's declining, slowly or quickly. It's very difficult. People can get a little bit difficult to deal with when they're in that condition, and you have to put up with that, and so taking care of yourself is paramount. When somebody is debilitated, especially if they have dementia, be sure not to take anything they say personally. They're uncomfortable, they're afraid, they're confused. Who knows what somebody's going to say? Just take it as it is, do not take it personally, and deal with it as it comes. That's all you can do. It's very difficult sometimes, but that's all you can do. Listening and reminiscing. You're listening, the patient is reminiscing. Often as we get closer to the end of life, we start remembering things about our lives, talking about them maybe over and over again, because we're trying to make sense and formulate some purpose for having been here. And going through our lives serially often helps us do that. Most of all, don't judge. You might have a difficult relationship. This might be a mother that was never the mother you thought she should be, or a spouse that is so different than he or she was when you first got married. That's okay. Don't judge, because if you do, you will be harder on yourself and be harder on the patient. Keep it simple. Just take things as they are. That is so easy to say and so difficult to do, but that will save your sanity. The physical changes that happen as we get closer and closer to the end of life are these. Cool extremities. Often people have cold hands, cold feet, and then as that coolness moves up the body, that just signals that the body is keeping all the energy centralized to the important organs, trying to keep that entity alive. You're not going to worry about feet, legs, arms, hands. Noses get cold quite often, but just trying to keep the heart and the lungs and the intestines working, and so everything else is going to cool off. People will be sleeping longer, sometimes only waking up if you wake them. Oh, well, she won't wake up to have breakfast. She won't wake up to dinner. Well, chances are that person does not any longer need any food, needs no sustenance. As we get closer and closer, the body actually can't process the foods and the fluids. So they can cause more problems than helping when somebody gets close to death. Disorientation. If you do wake them up, they don't know where they are, they don't know who you are, it takes them a while to kind of get their bearings, and that just kind of signals that maybe you just want to let them sleep and just move them occasionally, reposition them to avoid skin breakdown, keep them comfortable. Incontinence, muscles relax, we just kind of lose control of things, the signals aren't quite getting where they need to from our brain, and so a brief and usually a Chuck's underpad is necessary. Congestion. The lungs are made to expand and contract. If they don't do that and they're just lying down, things will settle in the lungs and you're going to hear congestion either at least up in the upper bronchial passages and in the throat, and sometimes down in the lungs as well. And we have medications to handle some of these issues that come up just to try to make the family comfortable and to make the patient comfortable. You will most likely see changes in breathing. A lot of times people will be breathing quickly and very shallow. Sometimes they'll be breathing very slowly where you can hardly even detect their breath. And sometimes there'll be apneic episodes where somebody will be breathing at whatever regularity, and then they'll stop for 10, 20, 30 seconds, and you think for sure that's the last breath, but not necessarily. Sometimes after that period of time they'll start again, and it'll be pretty much like it was before, but then that will continue possibly to happen, and then finally the last breath will be taken. There will absolutely be decreased intake and decreased output. We talked before about just complete loss of appetite and the body's inability to process the nutrients. That will happen at some point. And obviously if you're not taking in a lot, you're not putting out a lot. So that is both urine and stool will decrease. If somebody lingers a bit, you know, sometimes things are sudden, but quite often it takes a few days for everything to shut down. So withdrawal is just kind of part of all the other things that go with it. You know, it's very difficult to get the energy to interact with somebody, just always tired, very weak, not wanting to really eat or drink or talk. And so people just kind of go inward quite often. And they might not even respond to you unless you really make a huge effort. And that's, you know, just part of the deal. Sensory experiences like hallucinations, for example, first of all, we don't know for sure if those are hallucinations. We perceive them as hallucinations because somebody is seeing something or talking to someone that we are unable to detect. But until we're in that spot, we don't know if that's a hallucination or if they really are seeing somebody that we can't see. So just go with it. Don't try to convince anybody that they're not seeing what they say they're seeing. Chances are they won't believe you or they won't understand, and it'll just cause friction. So just go with whatever is happening. Restlessness. I imagine that as we die, there is a change in how we feel. Even if we're not in pain, we know that something's going on. You know, systems are shutting down, things are physiologically changing inside of our bodies. And I don't know this to be true, but restlessness would be a natural response to that. You know, just not really knowing quite what's going on. And, you know, whatever the reason, restlessness is common. There's something called terminal agitation, where people get very agitated, and we are able to medicate that to keep people calm and comfortable, which is always our goal. New communications. By that we talk about making weird requests that really don't make any sense to you, or that are just really out of character for this person, making comments about things that you've never spoken about or you don't know anything about. And it's not really delirium, that can be part of it, but it can just be a different presentation. The person just is talking about different things than you are used to hearing. One of the things that loved ones can do, in particular when somebody is going through a death transition, is to give permission. We always talk about that, simply because if there's a loved one, a sibling or a child that this person hasn't spoken to in some time, and maybe they've expressed earlier, gosh, I wish I could see so and so again, or a daughter is flying in, and the declining person knows that this person is coming in, they can wait for that to happen. So if there's something unresolved in this person's life, and it's something that you can put your finger on, think about what you can do to present this person, bring it to resolution, say something to them, just basically giving permission for them to relax and let go, letting them know that things will be fine when they leave. Yes, you'll miss them, but you can take care of yourself, or so-and-so will take care of you. However you express it, that's relevant to your life. Saying goodbye. Remember, hearing is the last sense to go. If you have something that you've not wanted to say, or that you haven't been able to say, or have not had the time to say, talk to this person as if they are responsive. Even if the person looks like they're asleep, their eyes are closed, they're not responding to you, say what you need to say, because chances are they can hear that. And maybe it's something that they need to know so that they can let go. So once the body is actually gone, is actually dead, manifestations of physical death are kind of confusing if you've never seen it before. I've had people call and say, gosh, I think so-and-so has passed, but I'm not positive. I don't know how to tell. And a nurse always can come and double check, if somebody's in a facility. Sometimes we go, sometimes we don't, but if somebody's at home, we always go. That's the one thing that you always have to keep in mind. A death at home on hospice, we are there to help you through it. So obviously the breathing will stop. They might have the apneic episodes where, a few seconds are in between breaths, and then all of a sudden it starts again, but the last breath is eventually taken. Sometimes people release their bowels and or their bladder, but not always. The heart obviously stops. You can, if you have a stethoscope and you want to listen, you can hear it, either side of the chest. You usually can hear the heartbeat. You can try to take the pulse. Of course, as people get weaker, sometimes the pulse is not even really able to be felt because it's so faint. But that's one thing that we check when we come. We listen with the stethoscope to the chest. The eyes normally will stay open. If sometimes people close their eyes, but normally the eyes stay open, and they just kind of change character. They kind of get glassy, or dull. There's a change, and you can see it happen when it happens. The mouth usually stays open or comes open because it's a relaxing thing, so people's mouths do come open. And you can close it or not, you can close eyes or not. It is really your preference, what you want to do, if you want to get involved in any of that stuff. And then you also will see some discoloration. This will happen before the actual finish. You'll see some like splotchy spots on the feet or the hands, or various other places, but that's just the circulation has just kind of stopped. You know, there's not really an exchange, oxygenated blood anymore, so you'll see dark spots on the extremities. So that's my little short presentation on end of life. Once again, my name is Holly. I'm a nurse practitioner with Destiny Hospice and Palliative Care. There's our office number, the 877 or the 951, the fax number, my email, and my cell. If you'd like a presentation on any particular aspect of hospice, please feel free to contact us, and thank you for your time and have a good rest of your day.